Hello everyone, my name is Amr Al-Kamshushi, and today we're presenting the rest of the story of the case that we started with you last Thursday. As a reminder of what we said in the previous episode, this is a 16 years old male. He had esotropia, diplopia, near poor vision. He had an accommodative spasm that failed to respond to all medical treatments, and he had 3 strabismus surgeries done, and he still complained of the variable esotropia and diplopia. So, what did we decide to do in this patient? This is a 17 years old emmetrope with unrelenting spasm of accommodation. However, we took the decision to do a clear lens extraction and put an IOL to abolish his accommodation. In this slide, you can see the patient being prepared for the surgery. He still has the variable esotropia, and in his biometry, it's noticed that he has relatively large axial length, it's 24.5, and a flat cornea. We are not the first ones to do a clear lens extraction for the treatment of persistent accommodative spasm. Here are some studies of people who did that before us. 1 week after the bilateral clear lens extraction, his uncorrected visual acuity for distance was 6/6. He was emmetrope, and he was very happy. He said it's the first time he could see clearly in years. Of course, he was fitted with reading spectacles because we implanted a monofocal IOL. However, the story continues. The story doesn't end at this. The patient still has variable angle esotropia. He still has diplopia. Yes, he sees better for distance, and his problem is partially solved by the clear lens extraction. But it seems that he is still attempting to accommodate. Should we try to solve this by muscle surgery? He already had both medial recti recessed and both laterals resected. Should we attempt a Faden procedure? Or could this have been avoided by a refractive solution? For example, implanting a multifocal IOL or doing monovision, putting one eye myope and one eye emmetrope. Well, this patient still requires more to be done for him. At this point, I would like to thank the audience, and we are all interested to hear the commentary from our dear professors. Thank you.
Hello everybody, I am Mohammed Shafiq, Professor of Ophthalmology, University of Alexandria, Egypt. Thank you very much, Dr. Amr Kamshushi, for allowing me the chance to comment on your interesting case. Really, it's an unusual treatment for unusual presentation, and the cases of accommodation spasm in general are really uncommon. When we find such a recalcitrant case resistant to medical treatment, there is no other option left other than targeting the end organ, which is the crystalline lens, by removing it and implanting a kind of IOL as you did. Unfortunately, this kind of treatment was not enough to abolish totally the esotropic attacks. And I think I can describe this case better as spasm of near reflex more than spasm of accommodation. And in such condition, we have to abolish the near reflex by implanting a kind of multifocal IOLs. Previously, it was described for such condition by Dr. Totok, and who published it in the International Journal of Ophthalmology. But before going and replacing the IOL by a kind of multifocal IOL, we have to give it a trial if this kind of treatment will really improve the condition by simply giving a kind of bifocal glasses for the patient that are able to abolish the near reflex. If happen that they improved the attacks of the esotropia or diminished the attacks of esotropia, such condition we can go and explant the already implanted IOL by a type of multifocal IOLs, or implanting and add-on multifocal IOLs over the ones that you already implanted. Which type of IOLs, multifocal IOLs we can implant in such condition? Taking into consideration that the patient is 17 years old and he still have the chance to change or to increase this axial length, so we have to implant a kind of forgiving IOL to refractive changes. And I think EDOF IOLs are much better than others multifocal IOLs in such condition because they are really forgiving. And if we aim to a kind of mini monovision, aiming to myopization, a little myopia of -0.5 or -1 diopter in the non-dominant eye. This can solve the condition. Thank you very much again for allowing me the chance to comment on your interesting case.
Hello everyone from the Egyptian Association for Pediatric Ophthalmology and Strabismus. I am Galton Vasconcelos from Belo Horizonte, Brazil. Salam, bonjour à tous. Thank you Dr. Amir El Kamsushi for the kind invitation. I will start my considerations by saying the neuroreflex triad, accommodation, convergence, and meiosis, is not a reflex but a synchronic event. They happen at the same time, but once the accommodation is removed, the stimulus for the triad may be still there. Firstly, we might think, why does this boy make such a strong convergence effort, even though he had a 6.5 millimeters recess in both eyes, in both medial recti? Moreover, he had no neurological problem. I would ask about his reading habits, how many hours he uses the cell phone, how much time does he spend on the computer or tablets. Relaxing accommodation with plus lenses had no effect initially, as well as the drugs that relax accommodation and drugs that induce systemic myorelaxation. The cataract surgery for clear lenses have shown that abolishing accommodation has solved the pseudomyopia, but not the excess of convergency. I want to bring two situations for us to think. Isotropias cases at the beginning of the presbyopia that may get worse due to the effort for trying to read without any glasses for near. And in such cases, prescribing plus lenses for near reading with glasses might improve the situation. The second situation is patients with no accommodation at all after 55 years old, 60, whose isotropia get worse, treated isotropia, previous treated isotropia, due to the lack of near glasses. The patient tries to read without any glasses, and what we think the meiosis, part of the near reflex, could be used as a pseudo accommodation due to its increase at the depth perception. The boy keeps having stimulus for that after surgery, so two things I would suggest. First, adding multifocal glasses for near to avoid him trying to accommodate for near and even get worse. And one very important point, to analyze in detail his reading habits, especially during now the pandemics. The use of cell phone has increased a lot among children and teenagers. And I think the next step will be trying multifocal lens. I think the multifocal IOL could cause more blur and difficulties concerning the binocular vision. And for the moment, to my view, no more strabismus surgery to avoid a future consecutive IXO deviation. Well, I hope this can bring more material for discussion. Thanks a lot. Bye-bye.
Welcome to the second episode of the ePost Ramadan quiz. I'm Dina Hossam, Assistant Professor of Ophthalmology, Cairo University, and I will be presenting the following case. A 7-year-old girl who presented back 4 years ago with intermittent severe headaches accompanied with blurring of vision that has been occurring over several months. She was a myope and had a manifest refraction of -6 diopter spheres and -1 diopter cylinder in both eyes, and was correcting to 0.8 in both eyes and to 1 binocular. Her intraocular pressure was found to be 32 in the right eye and 34 in the left. Slit lamp examination revealed a clear cornea but a very shallow anterior chamber in both eyes as shown here in the pictures, unlike you would expect in an axial myopic patient. After dilatation, a globular, clear crystalline lens was found with no evidence of any subluxation. Her optical biometry showed an axial length of 21 millimeters and K readings of 42 and 44 diopters to confirm that we are dealing with a case of refractive and not axial myopia. Anterior segment Scheimpflug imaging of the right eye showed a transverse diameter of the lens of 3.9 millimeters, an anteroposterior diameter of 4.6 millimeters, and the anterior chamber depth was 1.3 millimeters. This was in her right. The left eye showed similar measurements of 4.4 millimeters for the anteroposterior diameter of the lens and a very shallow anterior chamber depth of 1.2 millimeters. And her corneal pachymetry was 570 and 580 microns in the right and left eyes respectively, so that the corrected intraocular pressure was the same. Fundus examination revealed a cup-disc ratio of 0.2 in both eyes, with no evidence of cupping and with a healthy neuroretinal rim. So it's obvious that we are dealing with a case of a microspherophakia. But the question is, what's next? So how would you manage such a case? Conserve and continue in medical treatment, knowing that the medical treatment has to be continued for life with the risk of optic nerve or field affection? Do a glaucoma surgery? Or do a lensectomy, knowing that the girl corrects to 6.6 in both eyes? And in case of doing a lensectomy, what would be your choice of the intraocular lens? How this case was managed is to be continued in the next episode. And we'll be honored to have Dr. Tachan Peter Chang, Associate Professor of Clinical Ophthalmology and Pediatrics, Bascom Palmer Eye Institute, and Dr. Nihal Shakankiri, Professor of Ophthalmology, Alexandria University, to comment on the case next Thursday. And thank you.